Kettering, New York, and he is a professor of medicine in Yale University. Dr. Ghassan, he is very well known in the hepatobiliary field, and he is one putting the guidelines all over the world. Thank you very much, Dr. Ghassan, for joining us, and the floor is yours. Thank you.
Thank you so much, Mervat, and good morning. And thanks so much for Dr. Mahous and Dr. Olayan for sharing this session. Again, also congratulations, Dr. Olayan, and as well as Dr. Shamari for an excellent conference. No doubt, actually, my dear friend, Dr. Turki and myself spoke beforehand about what we're going to talk about. So yes, there'll be some repeated components which already Turkey has presented impressively well. And so bear with us, we kind of probably repeat some of those components only to build a better story and just put things and connect them together. Again, it's a great honor. I would have loved to have you to be with you in person, but still, nonetheless, I'm glad still to be able to connect. These are my contacts. Please, you can take a picture or copy what you need. If you scan the QR code, you'll be able to connect with me or take a picture of it, or of course, copy whatever you need. And of course, the organizers have my contacts and they are readily available for you at any time. And with this said, I definitely would present the following agenda: epidemiology and staging. Yes, chemotherapy, as Dr. Faya already spoke about, but I'll repeat certain components of it. I definitely will spend most of the time on what I'm asked to talk about, which is targeted therapy, and then we'll finish by checkpoint inhibitors. Again, briefly to reiterate what Dr. Faya already has spoke about. So regarding epidemiology, this is a very straightforward story. Our epidemiology was very much dependent on anatomical presentations. We call things by where they locate. You know, if they are in, in the gallbladder, we call them gallbladder cancer. If it was in the bile duct, extrahepatic, we call it extrahepatic cholangiocarcinoma. Inside the liver, it's intrahepatic cholangiocarcinoma. Very straightforward. And the question is, as you know, historically, we all thought this is all probably the same disease, it's simply just different location. But clearly, we were wrong. If anything, the molecular component of the study that has been done here and there really revealed to us that this cancer, after all, is totally different based on where it is. And as such, we proudly introduced this concept. Many of you remember 3 years ago at ASCO, when then we published it, which talk about mutual exclusivity or genetic alterations, where pretty much, in other words, a certain tumor can have certain genetic alterations. Number one, based on where the location is. For example, IDH1, FGFR2 are more intrahepatic cholangiocarcinoma. HER2 is more gallbladder adenocarcinoma. And at the same time, if a tumor happened to have a DH1 mutation, extremely unlikely, even though it can happen, but super rarely, it can have GFR2 fusion. And as such, this mutual exclusivity will give you quite a bit of guidance about how to treat the disease. So with those two concepts, we kind of will carry on to chemotherapy. And already, Dr. Faya already spoke about it quite a bit. ABC02, yes, it's a good standard of care that we are all using and dependent on. 8.1 month median survival for the Gemsys and close to 11.7 months for the Gemsys. Intriguingly, the PFS is also 5 months for the Gem and 8 months for the Gemsys. Many of us will wonder, like, how come the survival is that a big advantage, but at the same time, how come the PFS is also so well spread and looks at great? Remember one thing, in the UK, where the study happened, where Huon Valley is based in Manchester, they do not scan as often as we do. They scan way less. And as such, remember, you cannot decide a PFS except when the CAT scan has happened. And I would say, in other words, if we were to redo that study in the US or even in Saudi Arabia, I would say we'll not be surprised to have the PFS a bit lower than what we have seen. And this is what we have seen with other studies so far. The Gemsys nab-paclitaxel, yes, again, it was brought up. And I'm showing here specifically the phase 2 data. And we know that there is a phase 3 clinical trial that is already completed accrual, but we're waiting for the data. And this really brings in a very important kind of concept that we have to be very thoughtful of, which is what we call equipoise. are we ready and comfortable with the data based on the phase 2 data to really start using the triplet combination because more is better? Or should we wait for the triple phase 3 clinical trial? No doubt the NCCN went ahead and added on the triplet as an optional therapy, despite the phase 3 clinical trial is yet to happen, and simply because the data was very positive. But on the other hand, I would say we have to be careful, because we have to remember here that more disease, more drugs imply more potential for toxicity. And as such, the triplet combination, yes, might be helpful in regard to survival, etc. But when you throw it into a phase 3 clinical trial, it might not necessarily give you what you aspire for in regard to options. So at this point in time, I would say maybe a very young, extremely active, extremely functional, no comorbidities, no other medical illnesses. Yeah, I can understand maybe why I want to do the triplet, but our standard should remain Gemsys so far. We spoke also about FOLFOX based on the ABC06 as a second-line therapy. I would say here it remains a little bit kind of unclear in regard to what exactly is patient prior exposure to cisplatin means. Is it resistance? Is it like really tolerance? We're not sure. And this is really where your judgment is going to be very critical in regard to if you would apply FOLFOX second line, i.e., for example, somebody who really had a long course of Gemsys and now they have toxicity, would you do that? Number two is somebody who really did not respond very quickly to Gemsys, I probably would be a little bit more comfortable doing that. Regardless, it's an option that's available for us. And the most important add-on is what was just presented at ASCO this year. Proudly, it was done by our colleague Shang Yu from Asan in Korea. And as you can see over here, the combination of liposomal irinotecan plus 5-fluorouracil showed a critical improvement in outcome in this randomized phase 2 clinical trial, showing a PFS of 7.1 months versus 5-fluorouracil only 1.4 months. I'm involved in this, guiding the study, and of course, it is, and hopefully will become an option available for you for your patients. So as you can see, it's important to kind of recognize that we have many options of therapy, and the question is how to place them, because no doubt that one important component for us is the issue of the follow-up therapy that we can get in sequence. Systemic chemotherapy, yes, maybe first line still, but let's see where targeted therapy might come into play. Targeted therapy has been quite a bit of work. This is IDH1. It simply, will enhance the inhibition against 2-hydroxybutyrate, which will kind of, inhibit that kind of, uncontrolled replication of cells. We probably did this study and we led it worldwide. And we have seen that the PFS was 2.7 months as a median versus placebo 1.4 months. Very important to analyze that data. Number one, based on the patient advocacy, we were actually pushed to make sure that we do crossover in the study, because you can understand why a patient would say, I have IDH1 mutation and why I'm not getting the drug. So what we decided, patients who have the IDH1 mutation, if they were to randomize on the study, if they were to be on the quote-unquote placebo, and they were to progress, they can cross over to the ivosidenib arm. And as such, overall survival become a little bit of a challenge to really present, and that's why the primary point was PFS. You'll notice though, even though the PFS median was really limited, but as you kind of see where the blue curve goes on, you can see that at different time points, 6 months and 12 months, the percentage of patients in regard to PFS on the ivosidenib arm was high, 32 and 22%, while interestingly, it was not evaluable on the placebo arm because there was nobody there anymore. So clearly there was a clear impact and benefit from that therapy. And if anything, this also, despite that, we were able to delineate the survival. Now, this survival I'm showing first in regard to ivosidenib placebo based on the study. Remember, they crossed over, so everybody will have almost an equivalent outcome. But interestingly, there is in the statistics a certain tool we can use where we can say, what if patients did not cross to the ivosidenib arm. And this is what we come up with in the green, the adjusted rank-preserving, rank-preserving assessment of survival. And you can see clearly here that there was a adjustment now for the survival. It remains 10.3 months in blue for the ivosidenib, but now if patient on placebo remain on placebo is 5.1 months, again suggesting there's a clear improvement in outcome. We do anticipate and will not be surprised that ultimately we'll see the final outcome approved for use for us by the FDA. Now, important point, and this is kind of again, as we build our picture regard to sequencing, can patients change mutation? Yes, they can. Actually, we reported that from Memorial again. And as you can see here, this is a case of a patient with IDH1 mutation that intriguingly over time became an IDH2. And if anything, these things can be challenged. And that's why at least that brings to the point, do we have to biopsy more than once? We don't have yet an evidence or a standard for that, but at least it's food for thought for all of us to think of. And by the way, the same thing applied to FGFR. First, to begin with, remember FGFR is a very big field that consists of many things, among which number one, yes, it can mutate like everything else. Yes, it can translocate. It kind of, choose between two different chromosomes. And thirdly, it can fuse. And kind of those fusions, especially FGFR2, will be the drivers for the growth of the cells. A lot of work has been done in that regard. Now it's called infigratinib. This is work that was done collaboratively among all colleagues in the US, especially. And you can see here clearly, yes, there's clear response, evidence of valuable response that led to ultimately the approval lately of infigratinib as a standard of therapy. And along that line, also pemigatinib, which proudly led again also, which intriguingly, and to be fair, we cannot compare data, but nonetheless, the response rate was very robust, 35% partial response. And if anything, also with clear overall survival, which is like one thing will look close to 18 months in the patients with the FGFR fusions. Other arrangements, including like, for example, translocation mutation, had a little less survival improvement. And of course, if no mutation, was a very limited survival improvement. With this said, some experience we just presented a few weeks ago at ASCO was the experience of patients with the FGFR2, but now without therapy. What happened to those patients? I think we're all interested, like, what does it mean to have FGFR2 fusion, but not necessarily receive anti-FGFR2? As you can see over here, yes, maybe the survival was higher for the patient who was with overall survival 23.2 months compared to no FGFR2 fusion 8.7 months. But I would really read this very carefully. This is a very small sample size. As you can see, it's not like we have too many patients, only 15 of them in the fusion arm, which implies how rare it is, about 5% of the patients. And at the same time, it needs to be subject to interpretation. So I would still, if I were to talk to a patient, I would not imply, oh, by the way, great, you have FGFR2, it means you're going to feel better. No. I will just keep it as silent. It's good to have because now it can give more drugs, but it doesn't mean that's going to have survival, despite that positive data that we showed at ASCO. And by the way, we had also, intriguingly, to kind of make that argument further, the PFS did not matter much. 5.6 months for 3.7, I wouldn't make too much out of it. It's not really statistically different. And I would say it's a good exercise we did, but at the same time, it's bringing still more questions than answers. And interestingly, one other things we did, which it is very much worth looking into, is who benefit more from anti-FGFR2 and when do they do that? So again, this is another effort that we published at ASCO just lately, is we looked in the pemigatinib study about patients who received first-line therapy, second-line therapy, and when did they receive the pemigatinib? Did they receive it as second line, as you can see in green, or as a third-line therapy? And interestingly, we found the following, that after all, patients who receive second-line chemotherapy, of course, they fare the best possible, as we heard from the discussion of the chemotherapy by Turkey. But on the other hand, interestingly, if you give pemigatinib, yes, of course, applicable for the patients who are, can get it because it's they have the fusion or the alteration. Yeah, definitely they did fare better. But more importantly, is that independent, regardless if they get it as second line or third line therapy, they will benefit. And again, you can see now how we're building the story in regard to the importance of the sequencing per se. And we go back to the issue of genetic alterations that can occur along the way. This is a beautiful work that was done by our colleagues at the MGH in Boston. And in it, they found that actually after a while, if a certain anti-FGFR2 is there and you were to apply certain inhibition with anti-FGFR2, specifically they use infigratinib in that setting, patients might change alteration at some point in time, creating resistance. And interestingly, as you can see here, one of the gatekeepers of this alteration is what we call FGFR2 V564F. Can you overcome it by changing to another anti-FGFR2? Presumably, yes. Will the study occur? We're not sure. But one concept that one might argue is, would you give, for example, a infigratinib, get resistance, move to maybe pemigatinib? Maybe. I admit, the first time ever I did it was just last week, because I had a patient who really robustly did not respond at all to the use of pemigatinib. But to be fair, it was an FGFR2, not fusion, but rather a rearrangement between chromosome 1 and 10. So if anything, I moved the patient, and we didn't start it yet, but we're in the process of getting the drug to derzatinib, another anti-FGFR2, because of the presumption that it might alter or affect alterations like a rearrangement, as I mentioned, more than a fusion. So we'll just wait and see. And understandably, I mentioned that beforehand in regard to the IDH1, IDH2. The only reason I'm bringing it up again to only reiterate that, yes, it can occur. These tumors, after all, they are under a lot of stressors. The question now, which, however, is important, how does this happen? Is it by random? Like, in other words, yeah, the tumor just feel like I'm going to change to something so I can grow whatever it is? Or is it more by a certain kind of pre-planned mechanism? We have theoretical perspective that actually it's a pre-planned mathematical model, what we call a chaos. As you know, in mathematics, chaos is not like just chaos, like random. It is actually a fractal that will depend on a certain prediction that occur and cause things to happen. And it will be nice if one day we'll be able to learn the chaotic phenomenon that will evolve the different genetic alteration from one to the other. And the last point, by the way, which is important, this is nice work that was presented by our colleagues at MD Anderson in regard to the combination of darafinib and trametinib for patients with super rare, barely 1%, but they exist, BRAF V600E biliary cancers, and with excellent response. And actually, I was interviewed about this and said, like, would you use it? Of course I would. This is a very important, when you have an alteration like this, even as first line, I would not sweat over it. I'll just go ahead and do that. Because remember, now we are identifying not only what can kill tumors, but what is the driver for the tumor, like the genetic alterations that we have, as we just gave several examples. With this on regard to the checkpoint inhibitors, exactly as Turkey just mentioned, yes, number one, in regard to the issue of MSI high, please, the most important for us is to remind our patients it's not common. In other words, they don't want to come and say like, oh, I want to check how many mutations I have, or if I'm MSI high. As you can see in the green arrow, for it to happen in cholangiocarcinoma is relatively uncommon. And in other words, yes, would I do it? Yeah, but I would not really bet on it as being like the ultimate answer to things. And number two is in regard to the use of checkpoint inhibitors in biliary cancers. Yes, there has been efforts that have been tried by many people. And we can see over here in regard to the use of nivolumab with clear benefit that was quote unquote independent of the line of therapy, but at the same time might be dependent of the expression of the PD-L1 or PD-1. And no doubt that also a doublet combination that we already know about, durvalumab plus tremelimumab, anti-CTLA-4 plus anti-PD-L1. Interestingly, this time with gemcitabine cisplatin add-on, great work that came from Ghassan in Korea that really shows that very complex combination of therapy with a great improvement in outcome. But again, interestingly, we have to wait for more data. And here, the argument that we're making is that probably, after all, what we are providing is a enhancement in outcome based on a certain further dirtying the tumor with the chemotherapy that will permit for the benefit from the checkpoint inhibitors. And by the way, it's not only with the durvalumab, nivolumab plus EP, same kind of concept in a way, which is okay. And you can see it here from our colleagues at in Michigan at Ann Arbor. And by all means, yes, it could be valuable as well. By the way, this is independent of what we're talking about here. We're kind of a little bit intrigued by the use of EP because we know that anti-CTLA-4 are rather very toxic. While interestingly, the tremi was given only at limited dosing, like only one dose, and this might kind of like circumvent some of the toxicity. I know that not in the subject of we're discussing today, but the Himalaya study in HCC will try to answer that question in regard to the single dose, one single dose only of the tremelimumab. And by the way, we probably did some work on the atezo plus comimetinib, and this one, as you can see here, it did show some potential intrigue of value in regard to the intervention, but again, too early to really come to any conclusion. So as such, I would say that we have a new era in the treatment of cholangiocarcinoma. I would say like 20 years ago, we didn't have the time to even opportunity to talk that much about different alterations. The mutual exclusivity of the genetic alterations, yes, it can drive certain therapeutic decisions. Actionable genetic alterations are evolving quite a bit, and we spoke about some of them, including FGFR2, IDH1, BRAF, 600E, and of course, even though we didn't discuss it, but for example, HER2 and gallbladder cancer especially. Resistance to potential chaotic phenomenon, yes, is definitely there, and of course, checkpoint inhibitors. So if I were to reiterate, what do I do if I have patients with certain alterations? I would say, as phase one, as a first-line therapy, chemotherapeutic intervention, based on the genetics, I would move on to whatever options they have. And then probably in regard to immunotherapy, I will keep it till the end kind of line of choices that come later on. Again, I thank you very much for listening, and thanks again. I pass it back to the chair. Thank you.
Thank you, Ghassan, and it's good to have you always. So we'll keep the question at the end. We have our